page down on the keyboard?
Okay.
There we go.
Thank you.
Okay, so my apologies. So providing communication and support is a challenge, which we all know, which providers, right, that are utilizing different terminology and spend most of the time with patient care. We don't have time to come up with a different language, right? That's why we have ICD-10. That's what that was supposed to do for us, was to create that common language, whether you are a layman or whether you are actually a clinician. So then, utilizing technologies such as telephonic communication has the potential to reduce costs, which we all know why we're trying to reduce readmissions, correct? However, there has been limited structure to the telephonic questionnaire survey. Why do I say this? It's because no matter what company you call or what hospital, we're all using something different. Some people use Boost, some people use Red, some people create their own. Gentiva probably has one of their own. ACE probably has one of their own. Doctor's Choice has our own. We all have something different. The problem is no one's speaking the same language. You'll notice that this common thread is the same language, and that is the hospital, home health, SNF, whoever you go to. So the Condition Expert tool can bridge the gap through a telephonic process or the interview process. This can provide a singular numeric terminology to provide providers across the care continuum with an opportunity with true patient-centered care. So if I were to say to you right now, you got a 65-year-old male with CHF who doesn't take his medications, who's smoking, who doesn't follow a low-salt diet, what would you say that person is? I'm sorry, what was that? Non-compliant. That's true. The patient is non-compliant. But what the hospital sees as non-compliant, what we may see as non-compliant, is completely different, correct? Because they're going to have a care plan when they release that patient to our care. We have to develop our own based on the OASIS, and then of course, again, there's no gap, or excuse me, there's a gap, correct? We're not talking the same language. Patients released with all this information from the hospital, they get into home health. Home health gives them a bunch of information, or the SNF gives them a bunch of information, and we're expecting these patients to somehow, through their anxiety, through their depression, through everything they're dealing with, to understand everything that's going on. However, if you were to go in right now and get your blood work done, it's your annual physical, what numbers would you be looking for?
Good ones.
But what does that mean? Define good. What are you looking for?
Normal limits.
Okay, but what? What are you looking for? What tests are they going to run? Sugar, glucose, what else? Cholesterol. Cholesterol, overall cholesterol, right? And then we're going to look a little bit deeper, and we're going to look at our LDLs versus our HDLs, right? Now, I'm not a clinician, but I understand this. I understand this language very, very well. Doctor calls me up and says, you have 115 sugar, James. I'm like, yeah, it's run high my whole life. So what? You got to get it under control. Will do. I'll lose more weight. So we're going to talk about a numeric terminology that will enable providers across the care continuum to effectively communicate and enable patients to play an active role in their care. Now, I know no one in here wants the patient to play an active role in their care, correct? That is not something we want. But it is, because this is what we all talk about. So what we're going to talk about is two things. We're going to talk about the disease control score, which is 0 to 100, and the patient effort score. These two scores will change the way providers across the care continuum care for their patients. Now, the beauty of this is I actually had help from two very brilliant RNs helping me develop this PowerPoint. And when we were finished, my goal was to make sure that they were content with what they saw. And I'm pretty sure they were. So let's talk about the disease control score. The disease control score is a non-modifiable risk factors. All right, look, if the patient has COPD, if the patient had a heart attack, if the patient has diabetes, they can't control that, correct? They have no control whether or not they had a stroke. Would you agree? Yes. That is a non-modifiable risk factor, okay? So we want to look at the DCS is to influence by anything that can have a negative impact on the disease itself, right? Examples of this, symptom severity, biometric data such as blood pressure, pulse, body mass index, any gaps in care. We look at find the patient's behavior and lifestyle, and of course that's, medication adherence, smoking, diet non-compliance, so on and so forth. Well, there's another side to this, and that is looking at the patient effort score, which is a modifiable risk factor. Now we've got two numbers here, folks, and I want you to remember these two numbers, because these two numbers are going to be how we communicate back and forth. You've got the disease control score, and then you have the patient effort score. As you can see, and I'm not going to read all this to you, it's basically what the patient can do to control the disease process. Are they taking their medication? Are they eating a low sodium diet? Are they following the care plan? Did they stop smoking? These are all modifiable. Would you agree? Absolutely. So the DCS together identify a priority score. So if I said the patient had, and we're going to talk a little bit about these two scores. We're going to take a 50-50. We're going to say the disease score is 50%, and we're going to say the patient effort score is 50%. Okay? These two scores are going to give us a priority score, 1 through 5. You may say, well, I want it 1 through 7. That's up to you. I'm just saying 1 is a patient that is the highest priority, 5 is the least priority. So when we run this and we see a disease score of 50, patient effort score of, say, 45, what does that tell you? If it's 1 to 100, 100 being best, if you see 45 under patient effort score, what does that tell you? They need what?
They're gonna need some help.
But it's also,
resources.
That's right, resources, education. The patient has to play along. They absolutely do. And now, before when we would say you have to play along, we didn't have anything to gauge, did we? We couldn't go back to the patient and say, your score is now 65. Good job, Ms. Smith. But in order to get better, in order to feel better, in order to stay out of the hospital, we need you at 80. These are the things you're going to have to do, A, B, C, and D. And that's what the system does. It actually creates a care plan for the patient. So this is what it looks like. Once you run the patient through the actual system, which is a CCM node, it gives you your priority. You'll see that first. So no matter who's looking at this, the first thing that clicks off or that you catches your eyes, the 2, 4, 5, 2 being the first patient, then of course you've got the date of birth, their condition, the date, doctor, provider, so on and so forth. And then you can see over here on the far right, you've got your 2 scores. You got the disease score, and you got the patient effort score. So when we were doing this, I wanted to look at, what does this look like? Because we all talk about patient-centered care. So from the hospital, if you can imagine the center is your patient, which is your hospital or your skilled nursing facility, home health, PCP, the condition expert wraps everyone in that bubble. So now everyone is following the same process, speaking the same language. So the patient identifies potential high readmit. Obviously, if those scores are coming down, what do we want to do? We want to intervene, right? As you see the patient scores coming down, we want to make sure we get somebody out there. We want to get an RN, PT. We've got to get eyes on the patient. So the whole goal when I was sitting down with these two RNs was, where do we go from here? What do we do, right? Well, the first thing we have to do is we have to run this in the hospital. We have to run this first in the skilled nursing facility. Wherever the patient's coming out of, we need a baseline, correct? That baseline, we're going to follow that moving forward. So when they're released from the hospital and they come into home health, we're going to take that patient after 5 days and we're going to go ahead and we're going to rerun to see exactly what's going on with that patient. Did they come down or did they go up? Now, if they went up, that tells us what?
They're doing good.
They're following the process, right? They're following the care plan. If it's gone down, what does it tell us? And we have to get out there and intervene, correct? Okay, so of course, what we're going to do is we're going to collect the medical history. When we run the system, you're going to look at your biometrics, your symptoms, psychosocial comorbidities, so on and so forth, lab adherence. This is what it'll actually look like. So the hospital will go and they'll run this. They'll put all this data in, and it'll spit out, once they go through and start asking the patient questions, very simplistic. Do you have difficulty breathing? Yes or no? Do you have leg swelling? Yes or no? Their weight. And this goes, of course, it's about a 6-minute screening. And once it's finished, it's going to spit out the score, but it's also going to spit out the care plan. Now what this does, it gives us 35 different workflows. So if they have a primary DX of CHF, or if they just had a hip or knee replacement, that's obviously what we're going to tackle first, right? And we're going to look at our secondary and tertiary as we go further down the line or further through the care process. So this is what it looks like when you're done. This is the results screen. The results screen, actually, you can see the active, inactive. And you'll also see right here, you'll see the priority. If the patient's a priority 2, you can see the disease score is a 69%, and of course the patient effort score is 72%. So what we want to do is we can start talking to the patient. Is this active or inactive? Do we need to talk about the patient needs symptom education? So that's active, so we need to go ahead and talk about that. Start educating the patient right there. And then we can click over and say, now this is inactive. We don't need to talk about it anymore. We've discussed it with the patient. So now we've got a guide, correct? So this automatically, like I said, creates a care plan, logs any issues, active or inactive. We can provide any kind of hyperlinks or education and content, automatically logs the patient to perform. And this is what it looks like with the CCM note when it's completed. As you can see, as you're reading down from this, you can see the demographics, the values and measures. Again, you see the patient control score, the patient effort score. And folks, this is a PDF. This converts to a PDF, which means you can send this anywhere. I can send it back to the hospital. I can send it to the SNF. I can send it to another home health company, a PCP, whoever's involved with the patient, that's where it goes. Again, we're all talking about, here's the active care plan. So we're all discussing all these points. Because remember what I said, when the patient leaves the hospital, they come into home health. We've already assumed that the case manager has discussed with that patient, yeah, this is what you need to do. We get them, we run them through the OASIS, we put them through our education. We haven't even reinforced what the hospital has done. This is going to give us right from the hospital or from the SNF, this is going to tell us right out the gate, folks, you need to start educating on A, B, C, D, and E. I'm going to send this to the PCP because we want the PCP to reiterate what we're talking about. Reinforce, 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 right? Because that's what it's about. We all talk about it all the time. The problem is we've never all been on the same page. And this is what the rest looks like. So again, you can see the patient education. There's your negatives. Any questions on this?
Is it edible? And did tough form?
Oh, I was going to say you can eat it. You know, probably just tear it off in small pieces. No, it's not. It's not editable, and I'll tell you why. It's because if you start editing this document, you start throwing everything off. Remember, this is coming right out of the system. This is coming out of one of the most sophisticated systems right now. And remember, that's why I brought the VA into this. They take care of the sick of the sick. And if it works for the VA, if the VA has already, it's tried and true, all I'm doing is I'm adopting their systems and saying, look, folks, the system already exists. We're just adopting it to what we need. Because the VA saves millions, if not billions of dollars a year running them through these systems. The problem is that nobody's going over to the VA and saying, do you mind if we borrow this? Thank you very much. Because they have some great systems. So this is, I just kind of developed the care wheel. You know, patient comes into home health, does the CCM note. You could send this to therapy, nursing, associated physicians, PCP referring to. But again, that top one may be the hospital, right? It may be coming from us from the SNF, right? LTAC. It all depends on where the patient starts. And folks, remember, this is about where the patient starts. And once the patient starts there, then we have to pick it up. As I said before, once we get the patient in home health, and what we're doing is that first one's coming from the hospital, the second one is done at day 5. After discharge, post-discharge, not post-admission to home health. Because remember, sometimes it can be 48 hours. You've already missed 2 important days. So as soon as we get that patient on board, 5 days post-discharge, we're doing it again. On day 15, we're doing it again. On day 30, we're doing it again. Why? Because now we have trended data. We see exactly what's going on. I can pass that information back to the care managers and transitional care managers back in the hospital or back to the SNF, and we can all see, is this patient going to end up coming back Or is this patient going to stay at home? Are we safe for that 30 days or are we not? And we can prepare for that. So as I said, the condition expert, it's a priority, right? You got 5 levels of triage. You've got the objective measures, which is your disease score and of course your patient effort score. It develops the care plan based on history and biometrics. And of course you've got the interventions, patient education, and reduce avoidable hospital readmissions, okay? Make no mistake about it, that's why we're doing this. We want to be a partner. We want to make sure that we can do something a little bit different, but have a drastic impact. And by the way, this around my wrist right here, that's what we're gonna send home with the patient, and that's gonna have all of their data. It's gonna have all their medications, okay, right there. This is what we all talk about, right? We wanna make sure we're making a difference. And to me, if we can all speak the same language, if we can all truly make it patient-centered care, then in my opinion, we've accomplished our mission. Any questions?
Who's gonna pay for your bracelet?
We do. Home health does. Yes?
If you were to take that flash drive and what format is it in? Is it going to be adaptable to Cerner, Epic, the rest? If
Well, I
they
think
go
if-
into the ER, are they going to be able to read on there what's on there?
I think if they put it in a PDF, if they convert it to a PDF file, then there shouldn't be an issue. Because you can store anything on these from Excel, PDF, Word. What do you guys currently use?
We use Cerner.
Cerner? Do you convert it at all, or do you just throw it on there?
The answer to that question.
Chris?
Yeah, probably just do it on Excel would probably be easier.
Exactly.
Who's responsible for making sure that that is up to date at all times?
We have a transitional care manager that will take care of that. And of course, the RNs that are in the home will make sure it's up to date.
Who at the hospital is going to initiate the first test?
I'm sorry?
Who at the hospital is going to initiate the first test?
My assumption, it would probably be either the transitional care manager or the discharge planner, whomever is actually releasing that patient. Remember, this is 6 minutes. It's very simple.
But
They're just,
discharge managers are not clinical people.
you don't have to be. That's the beauty of the system.
Yes, sir, no
You do
question.
not have to be a clinician to run this system. You can take somebody and you can send in a home health aide. You can send somebody who isn't even a part of it. And you can say, you know what, your job is to go around and ask questions to all these patients before they leave the hospital. This is when they're being discharged. This is our expectation. And you're done. What other questions? Yes, sir.
Just a small issue. Is there any way you can reverse your system in the sense that 1 is low priority and 5 is high priority?
Why not?
And as your numbers go up, you're more alert? Because everything we're trained is the higher, the worse things are with your sugar, your blood pressure, your cholesterol.
Yes.
Hard
Yes.
to think that if you come down, you're better.
These are my numbers. These are arbitrary numbers, okay? If in your hospital, but remember, that's what everyone in your hospital is going to have to follow. For us, I like it deep. I mean, other way, just because 1 means now, 1 is the first, second, third, kind of that priority in my head. But that's just me, okay? But absolutely, you
Yeah,
could do
level
that
5
if you
means
want.
really something bad going on, right? Level 5 is not.
Okay. I like that. I like that. What else? What are your comments? What are your thoughts?
Are you selling this software to hospitals right now?
No.
This is your home health company.
We're going to use this, yeah, right at the beginning, and then as we start to collect all the data, then I can't do anything. Steve will do what he wants, but the first thing is making sure that we start to build this out, and we start to see how this works and how this interacts with the hospital systems. We're excited because we know this is probably the way of the future. Especially,
Are there hospitals using it now?
no,
Except for the VA now.
except for the VA. The VA has incredible success.
So your disease-specific care plans, they're evidence-based and...
Everything that he built in these systems is all evidence-based. Everything.
Do they address comorbidities? There's only 35 on those.
Those are the 35 workflows. So remember, it's going to pay attention to that primary DX. If you want to run through a secondary, you just rerun the patient back through.
Up to how many diagnoses go?
I'm not sure. I think they run, he does 2,000 conditions, roughly 2,000. Yes. Yes.
I know you said the VA, or this is exactly what the VA used, or this is an adapted version of the VA?
The system does not change. Let me just say this. The system does not change from VA to commercial, okay, or to private sector. It's the same system.
So this
It's
is
all
the
coming
same-
from this. It's all coming from the exact same pipeline of information. So the same system that the VA currently uses, all he did was plug into the side of his own system and said, okay, now I have this adaptable system over here. So you're using the exact same data.
The reason for the, which I'd like to hear, that's good.
Yes.
Because in a standardized scoring system like this, we need to have a reliability study to test the sensitivity of the score. So I'd like
That's
to
right.
hear that if the VA had done reliability studies on this,
Oh,
that would be comforting to know.
when they did, just on his triage system, they pulled 10,000 triages once, and they wanted to see if, you know, how close were they, and he was 10,000 for 10,000. He's ran over 20, I want to say it's 20 million triages that have all been accurate. Remember, this system is all 50 states. Okay, this is the DoD use it. I mean, they're all using it. That's why I said this is what makes the system so unique. Because he's not out there running a publicly traded company. This is what he does. He's a physician. He's not interested in taking it public. Somebody asked me, are they taking it public? I said, no, that's not his interest. The VA is really his back door. It's his yard. That's where he plays. To me, I looked at this and said, this has a home in hospitals, it has a home in home health, it has a home in SNF, and it allows us all to speak the same exact language. I take that language back to that PE, or the patient effort score, and the disease score. Those are the two scores that, in my opinion, that when you're releasing them to the hospital and telling us that the patient has a patient effort score, a disease score of 65 and a patient effort score of 72, that lets us know right away what's going on with that patient. Just like when you walk in and you get your blood sugar levels, or you get your, your cholesterol levels, you know exactly what's going on. It's changed. I know it's different. But this is the direction, in my opinion, that we have to start moving. And when you start looking at the VA and what they're doing, in my opinion, we're just going over there and we're borrowing that information and saying, we believe that this can be utilized within the private sector.
So
Can you ask
question.
him,
Go ahead.
can you ask him if he has considered in the composite score the risk adjustment factor? Because not every diabetic is the same, not every CHF is the same. There's a lot of comorbidities, risk adjustment.
And that's where your biometrics right at the very beginning, that's where that's going to pick that up. So based on the yes or no, all the way through based on weight, insulin dependency, and it asks other questions within the system. I just gave you just 3 questions out of 6 minutes of questions. Yes, sir.
Yeah, I'm just curious, since the VA is 90% men, is it some unintended bias in the system that is sort of neglected in this?
I don't believe so, but I'm not going to sit there and say yes or no. I mean, he's a physician. I mean, he's an emergency room physician. Remember,
report on what he sees.
well, and also it's based on algorithms. Medicine is all based on algorithms,
Regardless of the sex.
right?
Yeah.
It's all it is. Yes, no, yes, no, yes, no. And that's all it is. It's just a big giant algorithm. And so what he's done is he's taken all that information, all those algorithms, and he's put it into the system.
I think it would help with those 2 questions you could bring to him, so if somebody. asks
Absolutely,
you again,
I love it. Trust me, I'm taking notes.
I mean, they do have body parts that we don't have, so I'm just curious.
Don't
Make or
claim
break.
it any other way. Yes, ma'am.
Just a question about the logistics. So is the vision, or has it actually been done that the patients will be given the USB bracelet and it goes with them to home care? Someone involved in home care in the home will take it out, put it in the computer, update
Yes.
it in the home,
Yes,
and use the patient's computer, put it in the
they'll have their own. Normally, our nurses all use their own lap. They all have laptops and so
There's no USB.
Right.
Yeah, so, it would, then I guess it would be to use, people use their phones and all that, but, so it would use something in the patient's home to update it, and it's 6 minutes done every week, every
Well,
month.
the 6 minutes,
every-
6 minutes is the amount of time it takes to run the patient through the condition expert.
Okay,
That's something we do, like I was saying beginning, we get it right from the hospital on discharge. 5 days later, we do it again. And this will be done by our transitional care manager. On day 15, not 15 days later, but on day 15 of post-discharge, it's done again. On day 30 post-discharge, it's done again. And then on day 60, it's done for the last time.
So every 15 days, the healthcare
Up
provider.
to 30, yes.
Puts in the information, does not have to be a clinician, it's just a period matter of questions, puts it back in the bracelet, and that's it, that's the.
They won't carry, the condition expert won't carry that data. All that data is housed within the transitional care manager. They'll have that data themselves. They'll have it on their personal PC or their work PC. They'll control all that data, and then they'll share that data back and forth with the hospital.
The bracelet's just the MedRec.
That's the MedRec. The bracelet's MedRec only. Anything else? I appreciate, yes.
What happens if the bracelet's lost? How do you, like, I'm sitting next to you, I'm showing you my bracelet, you're showing me yours. How do we know we don't mix them up? I mean, things like that.
Well, if it were me, I would take a little, black marker, and I would probably either sketch their name inside here or sketch their name here. So at least they have
But
it.
there's nothing on there
No.
indicating for like HIPAA violations, things like that. Okay.
No.
All right.
So it is password protected.
No.
This bracelet?
It's just
No,
the
it's just a
MedRec that has no
USB.
name on
But
it.
It just has-
when there are some USBs that you can plug in. And
This is not.
password associated before you
Yeah.
access personal
This is not.
information.
One question I have for you, I mean, the common denominator here still is the patient, and being compliant with as much patient education as you can stuff down your throat, and what to reduce avoidable hospital readmissions. And you as home health care provider, owner, whatever it might be, going forward, what success are you having with, yes, you identified patient education, you identified avoidable hospital readmissions, educating that patient even more. Are you getting through to those patients? Are they,
We're just
has
starting
it changed the
this.
paradigm
We're
of the?
just starting this. Okay. This is brand new. Yeah. You're first to see it.
Woohoo!
The very first.
But James, that goes back to the collaborative question. So the
Yes.
strategic plan for this. So
Yes.
Doctor's Choice is using it, but how do you see it as far as the collaborative piece?
Yes, what I
in
see,
all pieces?
absolutely, what I see happening is the first 6 months, Doctor's Choice is going to roll this out. We're going to go ahead and do all the legwork in the very beginning. Once we show the efficacy, once we show that this works, I mean, we're not going to constrain the hospitals or tell the SNFs who they can and cannot use. I don't believe in that. We want to make sure we're opening the door to everyone. We just want to simply get it off the ground. I don't like being a Me Too. And like I said, this has been a vision that I've seen since 2007. I just want to make sure that we roll this out, we see that it works. It's not about me, it's not about Doctor's Choice, it's really about the patient. It's really about all of us speaking that common language and helping reduce the avoidable readmissions as much as humanly possible, helping our case managers in the hospitals, helping our partners in the community. That's the way I see it.
And any research associated with it that you're wanting to do along the way?
We will. I mean, we've got Chris that's going to really be kind of heading this up along with Frank Luna, these guys, and myself, and then we got one other gentleman that's going to be joining us.
Why is it all men?
I know. It's just, thanks for jumping into my head, pulling it out. Has nothing to do with men. Just so happens to be the team. I don't hire these folks, okay? I have nothing to do with it. Bring on a woman, okay?
Uh-huh.
They could fix that for you.
They probably could. Thank you, everyone. I appreciate your time, and thanks for having us out here.